care in a Super 6 diabetes model for delivering diabetes care differently. And this unique novel translational care service in Portsmouth, he created a hypo hotline, and he enabled a communication with ambulance and paramedical stops. He's also the co-creator of the TAT Talks, which is talking about diabetes in type 1, rise of machines in type 1, the technology guy, so we also call him sometimes technology car, and he virtually is everywhere. So he's like leading NHS England and NHS right to care pathway. In fact, many of these technology which you see which have an access in UK are all because of Partha, and he's really created a diabetes technology pathway for multiple stakeholders. He co-leads the diabetes grift process, and you know that he was able to get this AGP involved in a big way and allowed people with living with type 1 diabetes. He's really made a change, but he's also very passionate on various other areas related to diabetes, the vulnerable populations. He's a routine blogger with the British Medical Journal. Partha, thanks a ton for being a little flexible for our friend Dr. Sen, because he has another talk to do. You know, Bansi keeps everybody very occupied. And let us see what are your super sixes on COVID and diabetes from the United Kingdom. Partha?
Thank you. I think I'll start off if I share my screen just to say thank you.
Partha, you're not audible. You're not audible.
Okay, is that better? Better? Hello?
Yeah,
Better?
that's better.
Yeah.
Yeah.
Okay. I think I'll start off by saying thank you, Shashank, for hosting this, and obviously to Banshi and everybody else in the team for organizing it. And I think before starting off, and I'm going to give you the UK perspective and what's going on, I think it's important to recognize some of the fantastic work that is going on in India. Every country is different, and I think we sometimes get caught up in the who's doing what, and is this like a league table? Those of us who have grown up in India and have come to this country in the UK, the complexities of a country like India with the different health populations and work pressures is totally different. So keeping all that in mind, I think we must take our hats off to our Indian colleagues. And I know Shashank is doing a lead role in that for all the work that you guys are doing to keep things where they are. So without further ado, I will share my screen and hopefully you guys can see it. Is that okay? Excellent, good. So those are my roles. I'm a consultant in diabetes in Portsmouth. I also work with NHS England doing some advisory role and trying to guide the system. So I'll go through a very brief run through as to where we are, what we have been doing. Not going to go through this, but this is just to say that this is where the whole thing started. If you look back at it, first few papers came out and started saying, if you look at underlying disease, diabetes was clearly a marker when you see the initial few papers coming along. And at that point of time, when COVID-19 started appearing in the UK, what we said is that, well, we know it's got a higher risk. We linked to hyperglycemia because of acute and chronic effects. And at that point of time, all we knew is that age and obesity are possible main drivers. So what the policy was that we created these groups. One of the group was a vulnerable group. And we say anybody with diabetes, whatever your age, whatever your type, whatever your control, you need to be trying to keep yourselves as much protected as much as possible. So our response was to prioritize services. So one of the things about a state or a national funded system is you can actually dictate what you want to happen. So what we said very clearly is that most face-to-face services had to stop. But we tried to keep our foot services going as much as possible, especially the combined vascular clinics, etc. And we definitely kept our pregnancy services going because these are important times. We tried to make a very important point that inpatient diabetes services was important because we knew people were coming in with diabetes and they had to be looked after. And as a lot of people in this talk will know, a lot of our colleagues need simple help with diabetes management as well. So virtual support, and we had guidance out. So that's where we started off. Then what we did is we started working with our colleagues in London and Birmingham. So London was a first place which was hit by a significant amount of COVID-19 patients. And they gave us these 5 feedbacks based on the cases they were seeing. Some interesting things which allowed other hospitals to prepare better. We talked about atypical ketosis seen in type 2 diabetes. We talked about fluid replacement issues. We talked about the importance of how to manage a patient when they're being proned. And the important thing also was there was a lot of people with type 2 diabetes being discharged on insulin, even though they were diet controlled or just tablet controlled to begin with. So one of the things we wanted to make sure is that they had their follow-up in case they needed to come off it. So those were the initial findings from London. So we And the three main hospital, Royal Free, London, we had Guy's and St. Thomas's, and Bart's or St. Bartholomew's Hospital, which gave us some really good feedback. Taking it further, then we had a group of individuals all across the country, specialists who got together to try and guide hospitals when COVID patients came in. And as you can see, one of the things we were quite clear about, because we had lots of incidences of people without diabetes coming in with high blood sugars or new diagnosis. So we made sure that everybody who's coming into hospital had their blood sugars checked when they were coming in. We wanted to make sure that they had the ketones measures as well, because you had the higher incidence of ketoacidosis in type 2. And as you can see, we decided to stop SGLT2 inhibitors. As a country, we decided that it would be safer to stop SGLT2 inhibitors in type 1 across the board as a protective measure. We didn't do that in type 2 because we felt that the risks were lower according to the studies. But what we did say is that when they did come into hospital, because of the higher risk of fluid imbalance and ketones, we decided to stop it when they came into hospital. So those guidelines were out there. It was made publicly available. So if anybody's interested, it's free. You can have a look at it. It's on the ABCD website or the Diabetes UK website. Very clear guidelines about not only admission, but also management during the stay. And then final document which has come out is a discharge document. So how do you follow them up properly? So as I said, it's very simplistically done. If you want to have a look at it and you want to use it, you're very welcome to it. They're all there publicly and freely available. Then came out this first piece of paper from the UK, which was done by Ben Goldacre and his group. And I'm not going to spend time describing a hazard ratio or a chart to you all. So to those of you who love Star Wars, these look like TIE fighters in the Star Wars film flying around. But in simple plain terms, you can see what the impact of this is. If you take it from the top, this is an illness of the elderly. And that's a very important message when we're going out with messages such as diabetes people are at risk. And I think it's important to make that point that for a lot of parents and their worries about their children, this was to say that yes, you got higher risk, but it is lower than anybody who's older. So age was the most predominant factor. And then if you look at this particular trial, they didn't differentiate into types, but what they did was said, is diabetes an independent risk factor? The answer to that was yes. And the next question was, so what about your control? And as you can see, they took a measure of 58 or 7.5% HbA1c and said that if your HbA1c is less than 7.5%, you've got lower risk, greater than 7.5 higher risk. Very straightforward. And you can see the impact of BMI here as well. Weight was a big issue. Other salient points, because this was not just diabetes, this was across whatever deaths we had to begin with. You can see the impact of the age, the hazard ratio really going out when you're above 70 or 80. And again, if you had a hematological malignancy like lymphoma, etc., you can look at your hazard risk ratio nearly about 5. The same for if you had organ transplant. So big areas of learning from there. And I think the main point of all these is that we have had what we have had, but if there is a second wave, what do we do about it? Who do we protect? So from our point of view, when we saw this data come out from our colleagues, we said, I think it was our role then to look into diabetes specifically more in detail. So we undertook that work. And the first piece of work that came out and is coming out in the Lancet soon, hopefully it's in pre-publication and the papers are all out for anybody to see. You can see what we did. We looked at all the diabetes, all the deaths between 1st of March and the 11th of May that had happened in the hospital. And we linked it back to the diabetes database. So we're very lucky as a country to have a national diabetes database that every single person with diabetes has their numbers, their ethnicity, everything registered everywhere. And you can see the impact of that, what that meant. You can see here from this chart, we made a very clear distinction between type 1 and type 2 diabetes. You can see type 1 diabetes holding a higher risk. This was the first paper of its type, which showed that type 1 diabetes seemed to have higher risk. But important point being, again, if you look at it, look at the age. If it's less than 40, look at the hazard risk. It's so far away from what we would say is 1. So the important message is, yes, it's a higher risk, but the lower your age, you're more safer compared to somebody who's of older age. You can see the difference in the ethnicity. So you can see what happens when you are, if you're not white, black, Asian, and you can see the difference that's there. And you can also see what we look at is socioeconomic deprivation. So it's no surprise that if you're poorer, your outcomes are worse because you might have poorer health. So that has got a big bearing, obviously, in any country. So those were the salient points to begin with. This was a chart on a mortality, and you can see type 1 being categorically at higher risk than type 2. But it's really starts spiking up from the age of round about 60. So the simple point to remember is that if you look at the death, then of the patients that we analyzed, the type 1 diabetes average death was 72, so quite high, and the type 2 was 78. So you're talking about really high. And the ones who were of the lower age, most of them had complications like renal issues or cardiac issues, etc. Going forward, the next question we had was, okay, so we know what the impact of COVID-19 is. If you have diabetes, it gives you worse outcomes, etc. But the next question was, had as a population death rates spiked? And you don't need to be a scientist, you can see these are data from 2017, the death rate of anybody with diabetes in the whole population of the UK. And you can see what's happened in April. There's a massive jump in people with diabetes dying. So, and that's across the board. And I think countries which have been affected have probably had similar pictures. This was confirming, yes, it was a high risk. And yes, there's been a big spike in deaths come April 2020 in the UK. So some of the salient points we said as part of the study, we said that people living with diabetes face a significantly higher risk, no question about it, type 1 being more than type 2. But the biggest determinant was age, and it continues to be age. We tried to assure our younger patients or especially the parents to say there was no recorded death below the age of 20 with type 1 or type 2 diabetes, and the mortality absolute risk was very low, even under the age of 40. And in type 1, you can even stretch it up to 60. So really low numbers there, but with added risk. Higher blood glucose levels and obesity linked to higher risk. But an important point, if you go back to the hazard risk chart, and if you want, you can have the slides or the papers available for download. It was interesting to see what we call the obesity paradox. Too low a weight also was associated with increased risk. So the whole rhetoric that we should all lose weight wasn't quite true, which actually supports what a lot of our ITU physicians keep on saying. There's a thing called the obesity paradox. When you go into ITU and you're on being ventilated, you need some body mass there. So BMI less than 20 actually had the same risk as somebody with a BMI more than 40. Overall death rate of diabetes, as I said, doubled. And then you had the ethnicity issues, and a big issue was if you had background condition, especially kidney problems, you definitely a higher risk. There was a very strong correlation with EGFR on the hazard risks. And obviously the lower you EGFR, the higher your risk of death. So what did we do in response to the data? So we created a national advice helpline. So at the moment in the UK, if you've got diabetes and you're struggling to get in touch with your own center, there is a national helpline you can call if you've got diabetes and you're worried and you want to ask some questions. So that's been set up for about the last 3 weeks or so. We have rolled out a free education and self-management platform for everybody with type 1 diabetes, all ages. So that's been rolled out. It's been a week or so. It's been just come out. And it's free. You register, and loads of good content there, which hopefully will help people when they're stuck at home and we're worried about how to improve your control. There is a similar platform coming out for type 2 diabetes, and that's going to come out hopefully in the beginning of July. And this one is actually based on a, believe it or not, an RCT done actually a year or two ago called the HELP program run by UCL, showing that does digital online education program work. So that we are evolving and putting out. And finally, we have been talking to what we call our chief medical officer about, is there any groups of patients who should be highlighted as being at a higher risk, and thereby we should what we call shield them, i.e. protect them more at home and give them, make sure they don't go out, in the sense of making sure they have food delivered at home, etc. So finally, I think one of the big roles that we in a national role have had, we think our role is to reassure most people with diabetes. We use all the media outlets to provide consistent message about, yes, it's a high risk, so you can try and tackle your glucose control, but mainly speaking, it's lower when your age is lower. So that is important. And we have used, you name it, Twitter, Facebook, Instagram, chats, main media, whatever forum we have been able to get hold of. We have focused there, and we have tried to give consistent messages, made ourselves very open to any questions from the public as much as feasible. We continue to look at the data to pick any obvious triggers, and our next piece of work is looking at a bit more detail on the non-diabetic hyperglycemia or the pre-diabetes group. We want to look at the obesity side of things. It's not going to be right to finish off this conversation without dexamethasone, because it's come. So we appreciate the whole, and as Dr. Sen mentioned, dexamethasone is not for prophylaxis. It's not for mild COVID. It's for people in a hospital, either ventilated or on oxygen. But the important thing which we realize is that this is not also what has been touted as low dose dexamethasone. 6 milligram dexamethasone is about 40 milligrams of prednisolone. That is certainly not low if you have diabetes, as I'm sure all of our listeners know. So we are building a national guideline as to what you should do, and that should come out hopefully next week, about what should people do if they have dexamethasone and how do we support them if they come into hospital. And finally, there's a lot of talk about vaccine. So our government is trying to prioritize as to who should get the vaccine first. We've got healthcare professionals obviously in there. But one of the things we're looking at is how do we help people with diabetes get it quicker, because they're at higher risk. So if our data is showing is higher risk, then our view, why are we not prioritizing them ahead of the general population? So that's a conversation which we are doing right now. And I think that's it from me. So I will stop there and happy to take any questions. Thank you.
So thank you so much, Partha. As usual, you are unusual and outstanding, and you had so much of loaded data which you have done yourself, and it's been really great. I am very happy that you made one point on type 1 diabetics, that they were elderly, and that when that type 1 data came out, it became very distressful, and I got panic calls from a lot of my type 1 diabetic children and people at 20s and 30s. So what's your take for those, that group? Do you really feel that they are at risk? Many of them in India also now use pumps, and many of them are reasonably okay control. And what's
The risk is anybody below the age of 40 is very low. That's the reality.
perfect? Perfect.
What surprise people is when you see elderly people. It's not in our consciousness to think that type 1 diabetes can be somebody who are old as well, but we think that, right? The common consciousness, type 1 diabetes is just of the children, and I think that's quite important. But below 40, the only thing you can do is try and get your control better, but rest assured is my message to everybody out there, type 1 diabetes, try and look after yourself, that's all you can do. But risk is low.
Great. What are your insights? Because we are seeing a lot of people in Mumbai city which came with diabetic ketoacidosis as the first presentation. They were not known diabetics at all,
Yeah.
and they had glucoses between 300 and 500, and many of them didn't make it. So, and they died between 24 to 48 hours. And this was just like a glucose as a variable in this whole paradigm of COVID. Have you seen such cases in United Kingdom?
Yes, we have. As I said, in one of the findings that we picked up from London and Birmingham areas was a lot of people without any diabetes coming in, and we were picking them up too late, which is why we think it's national policy. To all hospitals, it doesn't matter who comes in. If they come in, you have your glucose checked, and then we've started picking up more patients who have got higher levels. So that has been quite a good learning exercise, and that would be my tip: is that there is certainly a number of people coming in without known diabetes and presenting as first up with you.
There has been a lot of thinking about this BAME category, and there are two paradoxes. One is affluent population, and one is an impoverished population. How can you mix the two ethnic groups? Because you see, the Asian population tends to be a little more affluent.
Yep.
That's one. And second, somebody has asked a question: is do you think that the vulnerable Asian population which died was predominantly vegetarian, or was there any link related to that, or had a poorer muscle mass, or was it having more body fat in their composition? Were there some insights among the BMA category on each of the ethnic groups, which were sort of outliers to that? Because we are living in India, and the Indians living in India don't seem to have that type of a risk. So what was the difference?
So there are two or three things which I think stand out. There's lots of theories, vitamin D, this, that, but as I keep on saying, if vitamin D and there was science behind it, then half of India would have perished by now. Okay, so let's be
That's
honest about where we are. So here is a few things that we have picked up. So I will divide it into two. One is the general population, the other is the healthcare professional. Okay, your doctors and nurses. If you look at the general population, the less affluent, very good data to show there is this. And that is one of my problems when people say Southeast Asian. Well, they're not one group. There's a fundamental difference between somebody who comes from India, Pakistan, Bangladesh, Sri Lanka. They're all different. And here, that's what we see. If you look at the kids, the children or the adults who come from more affluent households, there is a very distinctive difference between, let's say, people who are from Pakistan, Bangladesh, and India. Indians come from a much more affluent background, especially children in general. If you look at national data in the UK, because of maybe because of how they came along, because of the work they do, whatever. There is not necessarily that it's skewed towards Indian. A lot of the same population is skewed towards people who are black, Caribbean, and a lot towards Bangladeshi and Pakistani population. Okay, that's number one. Now, if you look at the healthcare professional thing, I think there was a lot in the beginning whereby a lot of people didn't necessarily put on the, and you know this, Shashank, a lot of Southeast Asian people have got, in my view, having seen this, having worked in India, that no problem, koi baat nahi hai. We will go and look after patients. We don't have PPE, we'll go on. Chalo, we have to do our job. And I think we need to be careful about that. Is that in the intensity and the passion that we have to look after patients, we should not forget that we have to look after ourselves as well. So when you see more elderly, let's say GP colleagues without a necessary protection, seeing patients who might have background diabetes or heart problems, it's not surprising that they have had that effect. So I think there's a lot of combination factors in here. Affluence is an issue, but not necessarily Indian population. And I think for healthcare professionals, I don't think if you look at it now, very few ITU colleagues have died, right? It's been people who are GPs or ENT, not necessarily haven't had the necessary protection in these initial phases. And I think that's probably a big bearing behind it.
So that's great. So they were a little reckless. So it's like the big message to our healthcare professionals across India who are listening to the talk is from Partha is that even if you are seeing diabetic population, they are not having COVID, please take appropriate PP precautions. Because that is every patient who's walking into you could be an asymptomatic carrier, and you are more vulnerable, and that's something which we need to know and we need to pick up. So that's a great question. You have also access to a lot of drugs, and you have these adaptive trials, research trials. So a lot of people are talking that we have been giving a lot of steroids is a rule of the day by general practitioners in India, and it is like a double.
Decathlon. My
Yeah,
training is in Decathlon. Yes.
absolutely. So the point is, now that this is done, I have actually a question on my WhatsApp. Somebody asked, now that the British have endorsed this and it's a life-saving drug, what would be the impact on glycemia?
Oh,
I'm not talking about ventilated patients, but
oh,
it's going to really skyrocket. So do
it
you
will.
think we'll need insulin drips, and have you seen a lot of requirement of insulin with all this?
Yes. So what we did, so actually, I mentioned the website. We anticipated that we would need a lot of insulin drips and pumps, and we might actually run out of it, right? So we have created a protocol which is not just via the pumps. We've also done it. How do you manage by subcutaneous injection if you run out? So both of those protocols are up there if you want to. An absolute valid question. But this is a big issue. And if we do have a second wave, and we go on to dexamethasone randomly and all that, for anybody, I mean, diabetes obviously high risk. I think there will be a big surge in glycemia, and you will need a lot of diabetes specialists to help out.
So we have observed in our ICUs in Lilavati, people need almost sometimes 200 to 250 units of insulin per day, and that's a very large. So what we are doing is to reduce that insulin load. We are actually giving low dose secretagogues and giving a long-acting insulin, so that subcute, so
Yeah.
that actually that net requirement comes down, so we can conserve some insulin, and that's something for you to look at and try. We are now collating our data in our inpatient care because we have seen this, and many of these patients are actually also getting a lot of methylprednisolone at the same time. So it's been very complex and complicated, but it was lovely, and I'm sure you can share the slides with Bansi in a PDF format so we can share it across to the people. Any other? Let me see if there's any other question. Do you all have favipiravir? Somebody's asked a question on favipiravir. Any comments on that, Partha?
No, not much actually. I mean, I think we're still waiting. I mean, in fact, in one of my WhatsApp groups just now, I've had my because obviously we all have WhatsApp groups of friends who are not doctors. So you always keep getting us questions, and I'm sure all of you do. And right now,
Yeah.
that's the latest one I've had. Should I start taking it? So I've said no. Hold on. Let's see how it goes.
Right, right.
So I think yes,
So
we're
it,
tracking.
yeah, so India, we have just launched Favipiravir. It will be available tomorrow. But the pill burden is very big. You have to take 9 pills twice a day,
Yeah.
and then 8 pills twice a day, and it's for 14 days. It has to be used very early, and it's been used in Japan and China, but the data is still it's a research mode drug. It's been available for restricted use. We have had some experience with remdesivir. Have you all tried remdesivir in
Yeah, it's
UK?
part of the recovery trial as well. So that's going on ahead. So let's see. Let's see.
Right. So we have that also, And have you all seen people with plasma?
Yes, we have actually. We have had a fair few people who have given plasma. So I'm anti positive because I've had my COVID tick. So we have donated as well our plasma to help people, and I've seen patients receiving it as well. So fingers crossed. I think we're measuring the viral growth in the way we go. But again, I think at the moment we're learning from each other. So I think going back to the point you made about the secret box, I think that's a fantastic idea. So if you can share something, we might have a look at it here as well. That'd be
Sure.
fantastic.
Sure. The other last question is that diabetics tend to have poorer antibody responses, and I'm told UK has you all have a lot of availability of antibodies. So have you noticed that the titers for covalescent plasma or the neutralizing antibodies are they lower in diabetics compared to non-diabetics, or there is
Yes,
no
so
difference?
good question. So that is actually something we should be getting some data on in the next 2 weeks, hopefully. So as part of the trial, because in the trial, that's what we have looked for is the split of the subgroup of the diabetes patients, what the titer comes back as. So bear with us. I mean, once we get some results, we'll put that out as well. Definitely.
Sure, sure, Partha. You are simply outstanding. We all love you in India, and stay connected. You are always 24/7 connected, helping out people here, particularly people living with type 1 diabetes and all our doctor friends and patients. So please keep doing all the outstanding work you do. And I think this concludes our session. And Partha, also thank you for being a little flexible for our friend Dr. Sen because and that's lovely. And I thank all our panelists from Dr. Juliana Chan, who was simply outstanding, then Professor Anup Mishra, then Professor Ittamar Raj, and Dr. Sabyasachi Sen, and of course the Parthakar we had. Thank you so much. You are wonderful, and thank you Dharmendra Panchal. You are also outstanding, and I think we are trying to finish on time.
Yes,
We are
sir.
8 minutes late. We are 8 minutes late, but I'm sorry about that. Normally I always finish on time, but my apologies because we had some technical glitches. It's not easy, as Anup said. We are into a learning curve of this virtual mode. But Partha, we wanted to see you in India, but at least I think we'll miss you at ADA and at ESD both. So we'll keep on seeing on Twitter. And thanks a ton again, all of you all. Thank you.
Thank
Thank
you
you,
so
Dharma.
much, sir.
Yeah.
Thanks a lot for your continuous support.